Welcome to the Caregivers Podcast. I'm your host, Dr. Mark Ropeleski, and our guest today is a returning guest from Season 1, Dr. Dean Tripp. He's a professor in the departments of Psychology, Anesthesiology, and Urology at Queen's University in Kingston, Ontario, Canada, and he studies chronic pain. Chronic pain is one of the most misunderstood kinds of suffering, especially when tests look normal. Today, we're going to explain what chronic pain is, what it feels like from the inside, and what caring for someone in pain does to the caregiver. Dean, thank you for being here. Welcome back. Dr. Dean Tripp, welcome back to the Caregivers Podcast, a returning guest. So happy you're back here. And boy, do we have some questions for you today.
Thank you.
Let's just start off and hit the road running. Chronic pain is not just pain that lasts longer. So, like in plain language, can you just tell us what is chronic pain and why do people misunderstand it so often?
That's a great question, Mark. I mean, chronic pain, I guess, frequently is misunderstood because it lacks visible evidence. And I think that, or markers, whatever language you want to use. And it also tends to clash with traditional medical models on how we think our bodies should be behaving. Pain is one of those interesting things where it's like when you're in acute pain, like, I stub my toe, I break a finger, so depending on the level of acute pain you want to be in, we have full expectation that it's going to stop. Like, I take a Tylenol, I take an Advil, I do some kind of medical thing and, I'm usually fine. But chronic pain is not like that. It's when a system is broken into a chronic state of alarm. And some of the key sort of reasons, I think, from my perspective, over the years, some of the key reasons from this misunderstanding really is about the invisible nature. Like I said, unlike acute injuries, you can't really see them. You don't see tissue damage. You don't see a broken bone. So chronic pain often doesn't have traceable tissue damage that shows up on even standard medical tests, works or scans. So there's no way, like it'd be great if we had a pain thermometer in our forehead and this thermometer would glow red when we were in pain, people would know. So there are physical signs of pain, but there's no standard testing that we can use to show us that you are in that pain. So pain is subjective. And that's one thing that makes it personal, makes it private. And I can be in a lot of pain and you don't know unless you ask me. And that is hard to measure because when you're trying to do this objectively, and then you're taking a subjective report as a physician, as a psychologist, as a healthcare provider, and as a caregiver. How do you know without asking how much pain someone's in? You can look at body behavior. You can look at different ways to kind of help code it. You can look at the changes in the human that you're dealing with, the changes in personality, the changes that we call it personality, but I really don't think I should call it personality. We might talk about that later. But I think the thing that's important to understand is there are these it's like chronic pain is to me like a false alarm mechanism. Like, and what I mean by that is in chronic conditions, the nervous system can become quite hypersensitive. And these pain signals that we have in our body, like if I smash my fist with a hammer, I'm going to have pain signaling from this point of injury up my arm to my spinal cord to my brain where it gets interpreted. So this kind of pain signaling system is often a false alarm or a broken on, like a fire alarm that continues to ring when there's no fire. And it's not like it's imaginary, but there's no more physical trauma that's happening, but the pain signaling is still there. That is a really hard thing for people to get their head around. And I think that's one of the biggest differences between thinking of pain being acute and thinking about pain being chronic. I mean, there's other things I could mention about it, like the diagnostic uncertainty.
Yeah. Well, I think it's interesting. I'm just going to stop you there because it just really resonates. It's not the nature of the injury, but the nature of the alarm.
Yeah.
And the alarm is probably, there are a lot of inputs into that alarm, which I think we might be getting into a little bit later, but I think that really seals it conceptually for me. And I think that's a key point for our listeners. It's not the nature of the harm, it's the nature of the alarm. So
that's a great way to say that.
People get told that, your tests are all normal. And in a blanket statement, you're fine.
Yeah.
But how can pain be real if all the tests and scans are normal?
Yeah. Well, first of all, like I said earlier, tests and scans are limited in what they're designed to do and how they're supposed to measure an event, if we want to call it an event. Because pain is an event. Pain is not like, how can I say, a static experience. It's an event because pain affects you as a person. Pain affects your physiology. Pain affects how we breathe. Pain affects respiration rate. Pain affects, the amount of oxygen, fresh oxygen we get to our brain, our ability to think concretely. It provides confusion, delirium. Pain is like more than just a single act. So it's an ongoing experience. And some of the things that are really important to understand, like societal and medical impacts of pain and chronic pain in particular. So we know stigma. And one of the big stigmas we have in chronic pain, and I'm quick to say this, is in how we approach people, how we treat people, how we care for people. And this includes medicine, psychology, OT. This includes physiotherapy, includes all the helping professionals. And because we sometimes think of people who have chronic pain as exaggerators. You know what I mean? Like they're exaggerating their pain. It's not an exaggeration. And the thing about remembering, pain is the fifth vital sign. And the most important thing about pain is what I tell you it is. Now, there are times when you can be stressed and that stress can elevate your pain. So does that mean you're exaggerating it? No, it means that your system is amped up and you're more vulnerable to that pain sensation than you may have been if you're relaxed. So that's not an exaggeration. That's a cause and effect model inside of pain experience.
Maybe caregivers, professional and the like, and allied health caregivers need to be taught more about pain. Maybe the lecture needs to be more than an hour. Maybe we need to understand the physiology of pain a lot better before we go trying to treat it. And maybe we need to make room for that. What do you think?
Well, I think there definitely is space that we're walking into. Medical programs, at least the ones I'm aware of in Canada and the ones my colleagues in the States and some of my colleagues over in Germany and the UK. In particular, there is changes in curriculum around pain education for physicians and surgeons. I mean, people who do a lot of these interventions. And I think that's a good movement, and it's still in the right direction. But I think importantly, one of the things we have to remember about chronic pain is that there's always diagnostic uncertainty. And that's the thing that I think ruffles feathers in medicine with pain and in caregiving, because it's uncertain. There's an uncertainty to it.
Because you don't want to miss the new acute thing that's happening, making the pain worse, or because you don't understand the patterning mechanism?
Yeah, well, exactly. So because pain is complicated, we see between, I think if I remember the numbers correctly, between 40 and 80%, pretty big gap of chronic pain patients are estimated to be misdiagnosed due to the reliance of improper tests and or the failure to take a comprehensive pain history. So when we're thinking about whether the pain is acute, what's the patterning of the pain? Is there acute pain inside the chronic pain situation? Like you can still get hurt and have chronic pain and have more pain. People think if you have chronic pain, you're just at a level. That's not true. So these myths, these misunderstandings, if you don't have dialogue, you don't have discussion, if you don't talk to the patient about their experiences, you're then going to go where? You're going to go to stigmas and biases or limited understanding of what their experience is. So I always say there's no easy way except to start communication on it. That's the smartest way to move, I think.
We've spoken a lot on the podcast to different individuals when we've looked at the range of availability of comprehensive primary health care in Canada, and it applies to numerous parts of the world. If your only recourse to present with an exacerbation of chronic pain is the emergency room, the intake of data about you and your pain experience is going to be biased by the nature of the environment by which you're actually presenting. And that's got to be huge, right? Because that's not the place
100%.
to take a chronic pain inventory effectively. The time just may not be there.
Yeah. And again, see, here's the issue with chronic pain. Well, there's a bunch of them, but here's one that pops out when you talk like that. Is first of all, the education, which we talked about. Like, what do you know about the pain? And what type of place are you being evaluated in? And is it appropriate? So it may not be the first time that you get looked at, but I can tell you from personal experience and seeing the ER work, there have been times when I've seen ER docs do very comprehensive and very empathic and relatively quick kind of pain assessments, including for patients in chronic pain. Because you'll see that. If you talk to your ER buddies, and colleagues around the world, you'll hear people say that, look, I've had a chronic pain patient come in and they exacerbated their pain from this injury, and I have to detangle where their pain is based on the composite of how they experience their pain to date. And that's complicated, But I mean, so I guess the bottom line is if you don't start asking the questions, if you don't ask broad-based questions and get an understanding of, kind of baseline, if I can use that expression, and then kind of current kind of promoters of more pain or antagonizers of more pain, then I think you're going to miss it. So you have to be careful to not miss that kind of relationship.
Well, shout out to our medical colleagues across North America and the world who are manning small hospital emergency rooms that are full and also being first call coverage to the ICU and the ward admitted patients, when you can be pretty sure that you're not going to get a comprehensive pain history in that case. So, Dean, for someone who's never lived with chronic pain, what does it feel like day to day, and not just the body, but in the mind of the person suffering of chronic pain?
Yeah, boy, that's a tough one. I mean, I personally have had pain experiences that have lasted beyond 3-4 weeks. I've had surgeries, but the patients I've been lucky enough to share time with, I've never had that experience. And part of what I gather from talking to folks and over the years and my own experiences and my research in combination is that it can be an empty place. And there's two major things that I keep hearing again and again is, number one, that you become a burden to others. And that is that sense of being a burden is connected to a whole hosts of other spin-off problems that people face, but it keeps coming back to burden and hopelessness. And I think that's what we hear. The reasons for those things are complicated, but they're not rocket science. Like, if you feel rejected by let's say your medical practitioner, and they say, look, there's nothing I can do for you. The way this is working, you need to go practice relaxation. And if you get that sense of being dismissed, and I'm not saying that this is that happens every day, but I'm saying if you get that sense of being dismissed by your medical practitioner and by other people in your life, that they just can't help you, can't get you going, can't understand you, don't have the empathy for you, don't have the sympathy for you. That's where I start to hear that word burden. So in terms of the experience of chronic pain, many patients I've talked to, because I've seen chronic pain and chronic unremitting pain. So when you talk about defining what the day's like, for some of those people, those days feel like that. I'm a burden and it's hopeless and it's never going to get any better. And that is a dark place to be. For others in chronic pain that I've talked to, and I've seen a variety of people who are post-treatment, whether it's physiological treatment or psychological treatments. And what they try to do is they just try to position living their life in spite of their chronic pain. And there's a difference between people who I find that are in a dark place with their pain versus people who have maybe touched that space and then moved out of it a bit, either by things that they've been able to manifest or the environment or combination of these things. So the day-to-day existence inside of chronic pain can be varied. It can be very different. So I think, again, how do we find out? We talk to the individual that's in pain. We ask questions about their day. We are open to kind of hearing their experience. And I think that is a good way to try to anchor the day-to-day experience for the person you're caring about or the patient you're seeing. So I think it's a good lesson to know that there's so many different places people can be that you have to kind of lean into that and be a bit inquisitive. You got to show the support, ask the questions, and provide some of that empathy and sympathy.
I think it would certainly go that to say that life experiences leading up to the initial trigger event that led to a chronic pain state probably have a way in shaping how comfortable and or how able an individual with chronic pain is able to step in and step out of that chronic pain experience and then enter that phase of, well, I'm living the best I can with it, as opposed to that feeling of hopelessness. They say that chronic pain changes the brain over time. And if you imagine the pain patient in their environment with people who care for them, their families, their caregivers, what are some of the most common, changes that actually occur, but that families otherwise would mistake as, the character of my loved ones changing, the attitude of my loved ones changing. There's, how do we sort that out, or what can we teach individuals to understand better about that effect of chronic pain on the brain, on day-to-day activities?
That's a great question. I think it's a two-part response. The first thing that I heard you say, Mark, was like, can pain change your brain? Like, and this goes back to the physiological talk we were having at the beginning, talking about, that pain is a physiological experience. It's not just a psychological experience. It is also a physiological experience. And one of the things that's interesting is there is research that talks about how, the brain can actually visibly be changed under assessment through chronic pain. We can say that's the mechanism that changes the brain. Now, I'm not going to, there are different studies out there that talk about, gray matter volume and different indices of the brain that go on, the activities ongoing and really will stay unaltered under chronic neuropathic pain, say, for example. But what we do see is we do see some subtle anatomical changes. And some of these places, it's called the prefrontal cortex or the medial prefrontal cortex, the anterior cingulate cortex. You'll hear a lot about that in the neuroscience talk, and sometimes like the thalamus or I think it's the medial dorsal part of the thalamus gets kind of altered in structure so it looks. And what's really interesting is it's like you see these changes, especially like in the prefrontal cortex in patients with pain, and it's really, when we think about what that area of the brain is connected to, that's when we start to talk about, personality changes, or attitude changes, or there's different changes in the individual. And one of the things that I hear a lot about is this idea of novelty seeking, because that is sort of a, if I can say, an area of behavior associated with that area of the brain. And if there's changes there, we can see even subtle changes in that activity or anatomy can result in a change in an individual's way of behaving. So reduced novelty seeking, if people aren't familiar with that term, is basically an interesting way of saying you're actively you're less likely to actively avoid monotony or potential punishment, which I guess is a way of saying you're less sensitive to future consequences. Or you can seem dulled. I've heard people say this. I feel like I'm dulled. It's like my individual personality is being effectively altered. And that may need some consideration. And people will say that, I feel dull. I feel like I am not motivated. I'm disengaged. You can mistake that first or rightly claim that as a symptom of depression if it's also deep enough. So to the answer the question of does physiological changes happen in the brain, the answer I think is resoundingly yes. Do we know exactly what does exactly what? No. Do we have some ideas that these changes may show up in behaviors? Yes, there's correlations there. There may be some other relationships inside of that we don't know yet. But I would say that these can change.
Yeah, there's a lot of popular talk these days about neuroplasticity and new connections and the ability of the brain to form new connections during, habit formation and other things. But from what we know, is this chronic pain state and the variable adaptation to it, does that reflected in deconstruction of pre-existing neuronal connections, or is it new connections that are forming? Is it like
that's a great question. I don't really have a solid answer for that. I can say that when we talk about flexibility and we talk about brain learning and we talk about changes in pathology, is the wrong word, but anatomy and function, we do see changes under extreme levels of stress as well.
Mm-hmm.
It doesn't have to be chronic pain. And we do see, if we think about chronic stress as something, as opposed to chronic pain, and I think it's equatable in my mind. But when we think about chronic stress, we see physiological changes in the body also. So we know they happen. In terms of, whether it's a degradation or there's a regrowth, or I wouldn't be able to answer that question. But I think there has to be play in that area. I think for us, one of the most important things I want to highlight is, yes, you can have sort of changes in your person, and I think personality is part of that. But you can also have changes that are pretty profound in your relationships. And that's where some of these changes in behavior show up. And I think that's also very important to anchor those anatomical maybe changes we're seeing to a behavior that manifests in the relationship. I think that's a key to make.
And then secondarily, yet reinforce again new behaviors or altered behaviors. So when pain in its chronic form becomes not just permanent in the patient, but permanent in the home, how does it sort of quietly change dynamics and roles and power in a relationship at home?
Oh boy, that's a great question. From my perspective, there's a couple things that happen. I think one of the things that, when I think about caregivers and I think about the home environment, I start to think about the spouse, obviously. And the spouse or the partner or the individual responsible for caring for this person, or that find themselves in that role. And when a spouse, I'm just going to use the word spouse for myself to anchor this. When the spouse shifts into a caregiver role, the first thing to break is usually that emotional or physical intimacy of the relationship. So it changes, right? Like when chronic pain comes into the relationship, it changes. And there's what often follows that, when that emotional and physical intimacy gets a bit ruptured, you often see a rapid breakdown in communication and, this kind of potentially emergence of resentment. So this shift from, this patient provider role, this spousal caregiver role, these roles of, role adjustments, they break down in a relatively common way several different aspects of the relationships that I think when you make me think about spousal changes and changes in the house, I just go to that immediately because the literature is clear. Patients feel that first. It's pretty significant in regards to how that stuff changes.
I'm sure it happens over a period of time, and it's not just instantaneous. And there are plenty of opportunities with greater understanding where you can actually intervene. So, patients with chronic pain, in the absence of a new acute injury, can have flare-ups of their chronic pain. We've touched on that previously when we spoke about some days are 2 on 10, some days are 7 on 10. But flare-ups can be unpredictable. And in the middle of a chronic pain flare-up on a really bad day, is there any advice that you would give caregivers in terms of what they should do, but also what they shouldn't do in trying to engage the chronic pain patient in a flare-up?
Yeah, I think, one of the things I mentioned earlier is this concept of empathy and sympathy and understanding how to, not be a rescuer all the time. And what I mean by that is the practice of empathy when someone is in a situation of distress. And I'm going to equate significant new acute pain on top of an existing chronic pain. Let's call that significant distress. You can't underestimate the power of just being. And what I mean by that is just not trying to solve the problem, or maybe you start off in solving mode, like, can I get medication for this? Can we do some kind of like heat treatment? Can we do a massage? Can we do a hot tub? Can we do some kind of meditation? Can you do your breathing exercises?
As partners.
As partners, can we do this? And that's an action event. Like, those are all things that you could pull out of your kit bag to say, these are options. Like, these are things that I can try to do for you, right? But I think when that kind of fails, and this is I think an important point from my perspective, when those quick hits fail, what are you left with? And our discussion at this point makes me worry that people are gonna forget that it's normal to be panicked at that stage.
As a caregiver.
As a caregiver. If I feel I can't help you and you look like you need help, I can't give something to you to fix it. Now I'm going to really be in over my head, right? Because I feel helpless. Now I feel hopeless. Now I feel like, I can't do anything. But you always can do something. And is you can offer your ear. You can offer empathy. And I talk about this acronym I have called C.A.R.E. And, the first stage in C.A.R.E. is it's C.A.R.E. And the first stage in C.A.R.E. is like concentrate. So when you start to feel panicked as a caregiver, part of the things I want you to do is just to concentrate on what's in front of you, which is the person. Stop the noise in your head, the worry about, I can't fix this, I can't, just stop and just zone in on the person.
The person you love. Yeah.
The person you love, and think about what they're saying. Like, just concentrate on what they're saying. Not whether it's right, not whether you can fix it, but what you think you're hearing. What are they saying? Think about that. That's step one. Two is really to attend to it. So now that you're kind of hearing it, now let's start to attend to it. What does it mean? So what are they saying? And have I seen this before? And give it some context. So attend to it. And then third is to reflect it. So now that I've stopped the noise, I've attended to you, I'm focused on you and your situation, which is difficult enough. Now I'm going to reflect it. I'm going to reflect it back to you because I'm trying to give you empathy. And the reflection of what you said often leads to empathy because now you think I'm hearing you, as opposed to me having some wish like, oh, no, just do that, it'll go away. I need it to go away. I want it to go away. Instead of that, you're saying, how, in this situation, I think what I hear you say to me is this. And then the person gets to correct you. Either, no, that's not what I mean. It's not about that. I'm just really frustrated right now.
I get it. So you're not just telling them, you're just having a bad day. No, you're actually reflecting. You're saying, I hear you. This is what I'm processing from what you're telling me. And the key, tell me if I'm correct or not.
Yes. Am I hearing you right? And that kind of discussion and that kind of refocus of what the issue is then leads to what so that's like the reflect, right? And then I think there's E, which is expand. So once we know this, once we've done these two little steps and we've reflected, now we can expand on it. Because now I know maybe by asking you another question, I can get to the root of where you're at, where your pain is. Is your pain more psychological at this moment than physical? Because you're stressed out and you think there's no control here. Can I help you with your feelings of helplessness? And that is an important place that people can think. Because remember, I just said you did everything you're supposed to be able to do. You tried all your toolkit, all your items in your toolkit, but you can always do what I just said. You can always care. And that care is an act of empathy because I'm listening to you. I'm slowing down. I'm not jumping in and replacing your words. And then I'm coming to the expand. Like, so what do you think, when we think about you being in situations like this before, what have we done before? Where have we been successful? What have we tried? And again, it's like this kind of idea, depending on the situation, right? Of course, where you're just trying to sit with them and help them look at where they are. That is an empathy. And sometimes you just need to shut up. You need to hold them. You need to put your arm around them. You need to hold their hands and look in their eyes and say, you're going to get through this. I'm here. And sometimes that is helpful because not everybody is looking for a solution. There's one thing I've learned in the years of my life is being directional all the time, looking for a solution all the time. When someone wants to be heard, can be abrasive, not what they need at the moment. So I think the care thing fits into that idea of what can you do when you feel like you've run out of things to do.
I could see on bad days when someone says, just leave me alone, you could have a cohort of caregivers who find themselves just walking on eggshells and trying to avoid conflict and potentially making the pain worse. What are the long-term consequences when the partnership has the caregiver walking on eggshells?
Yeah. What does it manifest to? Right? That's the real question. Like, you are going to be on eggshells because if you care for the person, and like I said, we have an acute fix model in our head about how life should happen. Like, for many people, if I come in and I complain about a problem, they go, oh, well, there's these things to do. Like, let's have these solutions. People by nature are solution finders. Most people.
People
Some are
pleasers,
not. Yeah, and you want to help somebody be better. I get it. And if you like that person, love that person, you're more likely to be the rescuer. I get it. I feel that role in different roles in my life all the time. Like, I want to rescue the person. But when you start to feel eggshells, to me sounds like I don't know what I'm doing. Like, I don't have a cure. I don't have the way. And now I feel that hopelessness and the helplessness. So when someone is really upset and I can't fix that, I might shrink away. And it may be from an aggressive response, like you said, if someone says, "F you," or "get out of my face," or, they're really aggressive in that way, excuse my language. But if that's the aggression that you face, that's a push because you can't solve that.
That's a hard push.
That's a hard push. And, when you get those pushes, you have to make a decision. Like, sometimes people will just go to the other side of the room and sit down. Like, you're not physically taking off, but you're physically giving space. Like, one of the things I've talked about forever in terms of psychotherapy and intimate moments in psychotherapy, when a patient gets visibly upset, would I, sitting across from them in a chair, come closer and closer and closer to them? Or would I, sitting in this chair, which has a standard distance, would I sit back in my chair a little bit, but stay engaged with my eyes, stay present, but behaviorally give them a little space? So sometimes people in these situations give space, right? But it depends on your person. Sometimes that outburst is expected because you're used to it. Sometimes that outburst, they need a minute and then they feel bad for it. And now you're into the second phase, which is they're more ready to talk about how they feel. Sometimes the outburst leads to another outburst, and you do need to get distance. So depending on the outcomes from what you get, those pushes, right? Sometimes those pushes follow a little bit of a pull. I need you. Sometimes those pushes are followed by pushes and pushes and pushes, and that indicates, okay, let's take a break. And that might be a distance break. It doesn't mean run away, but it depends on knowing your person. I think what that push represents.
Does chronic pain affect a pain patient's ability to show empathy, or does it deplete their empathy bank if the reaction of their caregiving partner is to distance, sit in a chair, and burst into tears?
I like the words empathy bank. There's no standard answer to that. I mean, I think the standard response for me on that question would be, try to do your best as a caregiver. Like, try to do your best. Will you make a mistake? For sure. Will you misinterpret the cues? More than likely. But the thing about it is, the beautiful thing about the relationship is it's not going to be over. Unless you say, okay, it's over, you pack your bags, you get on a train, and you actually physically leave the relationship. That doesn't happen. Let's say that doesn't happen. I mean, it could happen, but let's say it doesn't happen. Just sometimes feeling awkward as a caregiver or a provider, I think, is par for the course. When it gets rocky and you feel like you want to leave, I don't have any more empathy, or they're feeling like you're not providing empathy, or whatever the experience is, that's just the next phase of work. And that's how I like to think about it. It's not like, it's like it's a movie. It's not a picture. It's not a snapshot. So the event happened, yes, but it's what you do with that event in the next little bit that's the important thing. The event is an important signal, but from that signal, what does that create in the short term, like immediate? What does it create in the midterm, which is 2 hours from now? What does that create tomorrow? And I think that's the important thing for caregivers to remember, is that events are powerful, events can be stressful, but they are useful as signals to what you might do in the future. It's an analytical approach, I get it. And maybe, the stress that the caregiver's under is too much, and you can't put your head in that space. That's why I say to caregivers, think about the C.A.R.E acronym. Have it written down somewhere, something like that. Some, aid that helps
We're
you
going to put that in
from
the show notes today so people can actually see it, and we'll make sure your acronym's out there, because I think it just frames things so nicely. But you can see how space can somehow be created for pain to become the third person in the couple's relationship.
Yeah.
What are the most unhealthy patterns that sort of couples will fall into that they really need to dig themselves out of?
That's a good question. I like that you call it the third person, because in effect, that's actually a very smart way to think about pain, right? Because if you think about the third person, if you give pain its person, right? It's not Mark. Like, we know who Mark is. And if pain is a third person, that person has influence on Mark, but it's not Mark, right? It changes the way Mark might behave, but, perhaps it's not Mark. So this idea that, there's a third person kind of perspective on this is important. I like, it made me think about 1,000 things about how to position that language. But to your question, when we think about the impact on relationships, when pain becomes that dynamic, that what happens to the trajectory, there are things that we have to worry about. Obviously, impact on the relationship, number one. I think when I start to think about impact on relationship, I'm thinking about strain. I'm thinking about role reversal. I'm thinking about the non-pained partner who assumes more household financial caretaking duties, which can lead to a shift from, I don't know, say a lover to a caregiver or nurse. So this role reversal and this strain is a significant impactor on relationships. And I think when we see pain become chronic and fundamentally, we get so, like, when patients, I say they have their chronic pain career, right? Is the way I try to think about it sometimes. This third person gets introduced into the relationship. We have to worry about that, number one. Number two, because of stuff like that, communication breakdowns. Number three, I think, like I mentioned this earlier, but erosion of intimacy and what, physical pain, medical side effects from medications, diminish sort of self-interest or self-esteem, what that does, like even to hand-holding. Because if people go to that place where they feel they're a burden and they feel they're unlovable, these are the things that pay the price, like the erosion of intimacy, I think is very important to mention. Social isolation, again, couple doesn't go out, they don't do things anymore as a couple, they don't enjoy things even together anymore.
They don't look at each other.
Yeah. And I think
that's so important.
When you make me think about a third person in the relationship, there is this what's collateral damage to, I think, the relationship. And I think we can work on that, though. There are things that people can do, to manage this damage.
And I think acting early probably helps counteract the ingrainment or even the neuroplasticity that occurs in each member of the couple's brains in facing these recurring challenges and the behavioral reinforcement.
Yeah, and when I think in particular about the caregiver, and I think about, how can they avoid this damage? I call it collateral damage from, what chronic pain does to us. I think there has to be spaces and time, like respite zones, for example, where, you create an actual physical space or a dedicated time where the caregiver gets to go away from this third person, this experience. So maybe it's 1 hour a week where they go play bridge. I actually don't play bridge, so I don't know how long it takes. But let's say it's 1 hour a week where they go to a book club, or there's 1 hour a week where they do a hobby or something for themselves. Just when you think about trying to prevent the effects of that collateral damage, I think that those types of things are very important for us to emphasize. That, setting realistic boundaries on what you will do and won't do. Like, personal care, and cleaning and things like that. If that's a personal boundary setting, then you have to negotiate that, navigate that, as best you can. So I think those are part of what I'm thinking about when I think about how caregivers can try to control some of that relationship damage.
Being present, communicating, and saying, I'm here. We're going to take a break. In the tradition of our show, we'd like to welcome the production team. Fred, Graham, do you guys have any questions?
So, Dean, I'm wondering, most of us have been through a rough breakup, maybe a friendship falling apart. I'm wondering, because a lot of the conversation has sort of focused on the physical roots of pain, I'm wondering if emotional pain or psychological pain can be considered chronic, or if that's something that's completely different.
No, it's not completely different. I mean, what we're talking about, and what I think is important to emphasize here, that chronic pain is emotional pain. Like, it's inevitable. Because you can imagine all the things that we've spoken about, to this point. The loneliness, the burden, the depressive symptomatology, the anatomical changes in your biology, your energy levels, your ability to do things, activities of daily living. All of that has emotional weight. And this is one of the things that I think goes most misunderstood, is that pain, and I made this point earlier, but I'll do it again. Pain is a physiological experience, but it carries emotional weight. So they are equatable. Now they're different, like the pain of a breakup, the pain of a dilution, a diluted marriage, the pain of a death, like of someone you love. These are real things. You feel them also physically, by the way. And you often hear about people. You see people in mourning, you see people in grief, like hard grief, and you see the physical changes in them. Now, that may be mediated by lack of sleep, poor nutrition, drug use, and or a variety of other things that you gave up, like going to the gym or trying to be healthier. All of but you see it physically, and that's mediated by emotion. So I beg for people to understand that chronic pain is emotional. It's not like it's divorced or separable. And I think when I talked earlier about medical models, this is what I'm getting at. Like, for years and years, centuries, we thought that physical situations were not emotional. And we know better than that now. Science is very clear. So I love your question, because it is emotional. It is a combined event for anyone who's experiencing chronic pain.
Makes sense. Thanks.
You're welcome.
It's pretty foundational to the biopsychosocial model of medicine, or maybe we can even say the biopsychosocial model of caregiving.
Yes. Yeah, I think that's a fantastic way to say that.
Dean, if you love someone in chronic pain, why is the development of resentment not uncommon And what do caregivers actually feel guilty for, or what are the thoughts that they feel guilty for having when resentment appears?
What a word. What a word. Resentment in psychology is probably one of the most interesting words that you can bring up when you talk about relationships.
Well, tell us your definition and how you position it for this conversation, because I think there are a lot of listeners out there who, regardless of chronic pain or maybe in other forms of caregiving, develop resentment. So what's your operating definition?
Okay. All right. So, I first will start with I think the question to myself, which is resentment normal in chronic pain caregiving? And I would say, yes, the research would say that it is quite normal. It's very normal and it's common. And I would think that it is an expected reaction in chronic pain caregiving. And what I mean by that is resentment is often considered a taboo emotion that I think caregivers are reluctant to admit they have. So I'm glad you're speaking about the way
they feel like they're betraying their loved one, right? Or the person they're caring for.
So I'm glad you're talking about the way you're talking about it and you're bringing it up. But it's a natural response. Like, it's a natural response. It's a human response to long-term, overwhelming, and often the thankless nature of caring for someone who is with persistent, unseen pain, like we mentioned earlier, invisible. So why is resentment normal? Couple of things. One, first of all, I think that unpredictable, consistent, or persistent demands of pain, it is important. It wears people down. You've changed your role. You're in a new space. You didn't study this in university. You didn't study this in grammar school. You didn't study this when you were a child. No one gave you a book on how to be this person, right? So you're thrust into this role and you have chronic pain, which is not a temporary illness. It involves sometimes 24/7 care. It disrupts your life, disrupts your sleep and your schedule, right? So when we think about that, that's one reason why resentment would be normal, because that's what happens. Number two, we mentioned this already, loss of personal freedom and identity. I guess you might feel forced. You might feel forced to sacrifice things, hobbies, careers, social life, intimacy. And that with your partner. That part of your life with your partner can be truncated, it can be shortened, it can be wiped to the side. Again, you're losing something. And then isolation, lack of support. Thank God for your podcast. And the people who do work in the caregiving area. Because without that work, people will surely feel abandoned by family members, by friends who don't help, don't know how to help, or, that can lead to resentment, right? The effort you're putting in doesn't get appreciated by maybe the person you're working with or the people around you that are blind to what you're doing. And then we mentioned the invisible nature of pain. I could go on, but I think resentment is normal for these reasons, because these events lead to signs of resentment, and the signs are: I'm irritable, I'm angry, I withdraw from my partner. We mentioned that earlier. I feel like I'm being trapped. I'm a burden to myself. I have guilt. You mentioned guilt. I feel guilty for having these negative emotions, and guilt will put you in a grave. Guilt will age you. Guilt will put you in a hospital. Guilt is such a powerful poison. We need to not swallow that pill. And that leads to physical symptoms of resentment: headaches, chronic fatigue, feeling burnt out. So, when we think about why resentment is normal, I think we talked about that, what it looks like. We talked about that. But I think more importantly for me, it's what do we do about it? Right? I don't know if you were going to go there with your next question.
Well, one thing that stands out is this word invisibility, and so many caregivers on their journey feel invisible. They're providing the invisible care that the system is not holding itself accountable to. They're feeling invisible in the process. And now in this scenario, they're treating a symptom that's invisible.
Yep.
You can see where it becomes almost the perfect storm and how the invisibility amplifies itself in so many ways.
Yeah.
So how that's just, it almost seems insurmountable, but yet we need to move on. The caregiving relationship needs to survive. So much is at stake.
Yep.
How do we overcome the challenges of that path to resentment, and how do we turn it around?
Good question. I think in managing resentment, there's a lot of work that has been done with resentment as a term outside of chronic pain or whatever, but in relationships. And that work is really looked at kind of different pathways. And I have a couple I can suggest. Number one is with any emotional experience, you have to acknowledge the emotion. And again, you have to kind of quiet the noise down and acknowledge how you feel. Accepting that you feel resentment is always a first step in managing it.
So naming
it's kind of like some people say, own it, right? And I think you have to understand as a first step, you might feel like a bad person. You might feel that way, but you got to own it. You're not a bad person. You're in a normal experience. I just described how normal it is to go to resentment, right? So you're not alone. You're not an outlier. You are part of the many people that find themselves in this particular hard situation with that outcome. So acknowledging is number one. Number two, and I mentioned this a little bit, setting firm boundaries in your caregiving is going to be really important. So it may be necessary from time to time to say no to demands that either are too much for you physically or too much for you emotionally on that day. So there has to be some recognition of what is burning me out. What is creating this resentment? Where do I feel that resentment most? So anchoring that and looking to set boundaries around those hard places is going to be important. To do this, you need to step out. And what I mean by that is you can emotionally step out, physically step out. And what I mean by that is seek support. And I'm sure I've watched your other episodes in this podcast. You've talked a lot about respite care. You've talked about, actively, I think, trying to find people who get it. Like people who get what resentment and caregiver burnout might look like. People who've been there, right? So if you talk about support groups, therapists, even taking break with respite care to recharge yourself physically, being able to go out and walk in nature for 30 minutes uninterrupted, turn your phone off, go to the park, sit on the bench, contemplate life, take some deep breath, do something that gives you a clear break. And then on top of all that, I think we're mentioning this, but it's obvious to say, communication needs to be clear. Explicitly tell people, family members, what help you might need. Talk to therapists about what help you might need. People, I think, get stuck in that place that we talked about earlier where they feel they can't do any more. You can always ask for help. You can always sit with the person and be there present with them. These two things never go away. They never run out of energy. You can always do this, but they're hard because you have to go through these stages of trying to manage resentment before you can communicate what you need. And from a place of accuracy, of caring versus of anger. And I think that's really important. So prioritizing self-care. Someone said to me once, you can't pour any liquid from an empty cup. And that just makes a lot of sense. Self-care is essential to avoiding burnout, and it's essential to kind of managing resentment. So acknowledging, setting boundaries, getting help, practicing self-care, and trying to get to a place with your communication that's clear in your head and with the other people around you. That is how you can help fight back resentment. It's not the answer, but I'm hopeful that people can find pieces of that might work for them.
Absolutely. Just a follow-up to that, I was thinking as I was listening to you, we never know when we're going to enter a stage of our life where we become a caregiver.
Correct.
But are there certain individuals whose prior life experiences set the stage that they're just unable to participate in self-care?
Oh, yeah. Yeah. I mean, I've heard you mention this before and discuss this on your podcast. We've talked about it before. This idea that like everyone, I was talking to my wife about this the other night. She's also a psychologist, a pediatric health psychologist, works in the school boards. And we're talking about how much you have to give. And I said, she said, we've talked about a battery analogy. Like we have a battery. Like I think we have a battery that allows us to kind of give ourselves to other people. And if we don't recharge that battery, right? If we don't have time to kind of replenish that source, if we don't put liquid back in the cup, we've got nothing to pour, right? And one of the things I asked her, I said, you work with so many children that are in difficult situations, facing difficult educational situations. I said, how do you keep doing that? And she said, it's like, I do self-care. She practices self-care, but she also says, I have a special battery. And I loved it when she said that. I have a special battery for that. She said, now, I said, where's my special battery when I get a cold? You don't have that same battery for me. And if I'm, doing my usual whining about being sick, that you don't have the same battery for me. And she goes, no, I don't. And, she says, get better, get moving, get going. But there's truth in that. Like some people have a way that they are, that they have a larger battery and ability to kind of be with people in distress. They have a larger battery to practice, the self-care routines that allow them to have a larger reservoir for people that need it. So there is something about our dispositions, about the way we see our roles in life and the role we're in at that point when we are tasked with that ask. So I think it's a combination of things. There's no pointing at someone saying you're wrong or it's broken or it's bad. I think we just have to accept that some people bring different skills and talents to the table on this. And because of their own life, their caregiving battery might be small. And so they have limited resources in that way.
Yeah, probably shaped in big part by how they've been able to be with themselves in their own states of distress long before they became caregivers. So, even the most loving of caregivers might sometimes doubt the pain that's reported or even be numb to the whole pain narrative in their loved one. Why does it get to that point? And how do you recover and repair that trust if the patient or the person being cared for feels that they're not believed?
Yeah. That's a good question. Well, the way I see it is like this. It's kind of like, how do we go from like pain management to back to kind of like partnership, right? That's kind of where my brain's going when I hear you say that. Is that resonating?
Mm-hmm.
Okay. So I just wanted to follow in on that because I didn't want to be too far out in left field. So when I think about moving from caregiving, pain management to a partnership, I think you can make. I know you can make changes, and there are exercises that couples can do to help promote that feeling of engagement again, to perhaps rekindle some of that spark, that love that's been buried under distress. And I'll name a couple that come to my mind. Number one, I call it I didn't make it up, but I mean, I call it this 10-minute daily check-in. It could be 5-minute daily check-in. But it's like, I've said this to people before, set a timer. It's a 5-minute check-in. And each person shares what went well, what was stressful, and one specific thing maybe that they need from their partner that night. And that's a it's like I'm going to program, if you do that, I'm going to program healthy exchanges on needs. And that little check-in and that little thing about, what went well today, what was stressful, because it's not just about hearing what's wrong. I think if you ask somebody, and this was one of the things I when I was far more active clinically, I used to ask people this all the time. What went well today? And I would always start with that. And you'd be surprised how many people had to work so hard to find something that went well that day, something that was good in their day. And in fact, Mark, I had people who would be stuck there. And I would just wait. And then I'd get to about 2 or 3 minutes of kind of just uncomfortable waiting. And I would say, okay, so what this tells us is what? If you're taking this long to perhaps find something that went well or was good today, then we're not thinking of it and we're not seeing it. So we're going to change that.
Change
so the exercise is, we're going to do this every day. So because what happens when you get stuck between fence posts is you only see that much of the world. You don't see the bookcase. You just see this head. And it's like that you want to see more. So perspective taking. So asking what went well is super important. What went wrong is easy, right? But that 5-minute check-in, I think 10-minute check-in, whatever you want to call it, I would highly recommend that. Another thing that you hear people talk about is I feel and I need statements. This is, psychotherapy 101, which is basically, you want to replace blame and vulnerability using the script, like a script. And I'll put it in air quotes. I feel, and then name some emotion like distressed or upset or angry when a situation happens. Like when you come home and you just put down your suitcase and you don't look at me and you don't talk to me. Right? When you think about that, then you need to say, and I need a specific request. So this I feel I need script is one way to kind of do that. I feel I need. And the request could be hopefully reasonable. Like I need you to kind of, just come in the house, spend the 5 minutes with me and do blah, blah, blah. That checks into the 5-minute check-in. So these are kind of connectable. You can use them in different places, but that I feel I need is important.
Yep.
And that another thing you can do is take turns listening and speaking. Because often, I mean, like you do with me here, like you're listening, you're querying, we're going back and forth. I love the flow. It feels comfortable. You're allowing me to talk. Patients often don't have that opportunity. Because if I come home and I see you and I've had a rough day and my battery that we talked about is low and you come at me with this was wrong, that was wrong, this was wrong, this was wrong, it's sometimes difficult for me to be quiet in hearing that because I want to fix it and I want to move on. So again, that CARE kind of acronym is important to consider at that place. So basically, if I could boil it down, take time listening and then take times without interrupting and then take time to reflect. That's the key of the CARE process. So that technique, again, you can call it speaker, listener, whatever. There's a variety of different ways. But that process of listening and speaking and listening and reflecting, really, really important. I mean, there's probably, those are the major that come to my head at this point. But I'm sure there's more that you can do. But those are the major ones that I think I would suggest are important. And again, looking for local respite and support resources, super important because, they may be available in different ways in the area of the world that you find yourself in.
Well, in hearing what you're saying, I think of the 3 R's. So that's relational, rejuvenation, routine. And it really hits home. And it's what everybody needs to do. But in the setting of caregiving and chronic pain, maybe we need to do that even more or make sure that as we're thinking about all the habits we need to incorporate into our daily lives, that we make that one a priority. Speaking of R's, I could think of big R resentment and little r resentment. So normal frustration, which is the little r, and dangerous resentment. In a care partnership, what's the difference, and what's the first warning sign that a caregiver's like reached that crossing over point or crossing that line into like dangerous resentment?
I think a lot of people feel it physically before they recognize it emotionally.
Mm-hmm.
And I think I would start there. I would say,
so that chest tightness in the situation.
Yeah, like, you walk in the room, you see the person, and you kind of in your head, you're just like, ugh. Instead of like love or compassion, there's this kind of like dread. There's this kind of like, hate might be a strong word, but it could be, hate. It depends on where you are with this. But I mean, I think big R is palpable. Like you know it because it destroys relationships. And I think you feel it physically. I think that's why I was talking about trying to slow down and trying to kind of capture the thinking, like capture the emotion. Because if you just allow it to wash over you and you don't try to capture it, you won't know what you're dealing with. But I think people feel it. I think they feel it. And when you feel that way, fatigue,
neck
stress,
tightness, chest tightness,
the whole
cramps.
kind of anxious experience, cramps. I mean, I think that's a real tell.
And unattended to, I could see it amplifying exponentially. So once you start feeling those physical symptoms and the big R is an evolution, what's someone to do? What's the action plan in that moment?
I think there's a couple of things. And again, like big R's or small R's, I think big R's obviously requires us to really think, because big R's
act urgently.
Yeah. Big R's break things, right? So I'm a little bit more worried about that. But I think this idea again of validating feelings, like if we want to alleviate this, like, I think validating your feelings, validating the other person's feelings, very important. Acknowledging that you can love someone and feel deep resentment for them. That you can do that at the same time. I think that's if I could think about a way that makes the most sense to me, I think that's how I would move with that. That you can feel resentment and you can feel love for the same person. It's just they're going to be at different ends of the spectrum on any one day. And again, just seeking care, support, professional counseling. When we're talking big R resentment, a lot of times that festers, sticks, and breaks because it's above your pay grade. Like you just, mentally you're not, you don't deal with that well. It's like not something you have training in. Like put it in the hands of the professionals. And I say, when you feel big R resentment, you need professional help. I think that's very clear to me. So feeling that build from small R to big R, like I think just being aware that it's okay to be angry. It's okay to feel put out. It's okay to have that sense of burden hurt you too. Like it's okay, but it's what you do with that that's important. So, when I start to hear big R, I start to hear help, support groups, professional help. That would be for me the number one thing to do. When it's smaller, it's like caregiving in a sense for yourself, recharging your batteries, going outside, getting your exercise, sticking to somewhat of a normal routine for you as well. I think that's part of that smaller R resentment approach.
So a lot of our listeners may not be able to afford professional care. Are there any authors and experts in the field whose work you'd recommend a caregiving couple or a caregiver in a couple situation to turn to, or that couple to turn to get the process rolling when they've identified that resentment's crept in?
Well, like I mentioned earlier, John Gottman and his work, Dr. Gottman's work, and he's decades deep in work in relationships. And we were talking, you and I had spoken before about Gottman previously, and just about some of his work. Like he talks about resentment when it's toxic as this destructive emotion kind of born out of like an unhealed relationship and wounds. Like he's really quite poetic. But his years and years of research talk about working on things like criticism, the feelings of contempt, that's big for him, defensiveness, stonewalling, which is another word which means kind of like, how can I say, stepping out, like disconnecting yourself from the person, not allowing yourself to feel or being involved. So I would think that a lot of work, and a lot of his work has been put into readable self-help books as well. I don't have one off the top of my head, but they're definitely searchable and findable online. And I think, that might be a useful, I would suggest that reading. Like, I think that would be a good place to go. But I would also say, professional help can, and I mentioned support groups. A lot of support groups are free. I mean,
virtual.
Yeah. So you could step into stuff like that, right? And virtual, like you said. You can step into stuff like that. And again, the key that I talked about the first time I was on the podcast with you was taking that first step. Like stepping into it, leaning into the next phase of getting better. Because if you don't take that first step, if you don't try to find a support group, if you don't, like you said, even virtual, if you don't try to get a book but maybe you're not a book reader, right? If you don't reach out to a friend, a confidant, or somebody that you'd be surprised where support can come from. But if you don't allow yourself to kind of first recognize this and then move in on it, then you're not going to get it done. So just try to be brave. Try to take the step. And maybe you don't get it done on Monday. Maybe you don't get it done on Wednesday. Maybe it takes you 2 weeks to take the first step, but it's in the back of your head.
And don't beat yourself up for not having done it Monday and Wednesday, right? Because then...
Oh, good Lord, no. Good Lord, no. I mean, if you look at behavior change and you look at people trying to quit smoking, or, and I know seems like a left field topic, but if you look at people trying to change behavior, it doesn't happen overnight. And it only starts to really happen after many attempts. For many people, it's multiple serious attempts to change behavior before it takes effect. So you're normal. This is hard. So just even thinking about it is a victory today. And that can be the thing that spurs on the action. Just try not to let it go out. Try to keep that pilot light kind of lit up.
Long before we get to that stage of resentment, we may be experiencing symptoms of burnout. Initially maybe starting subtly and gently, but then amplifying. And we may still be functioning at a high level. Are there any warning signs for caregivers of patients of chronic pain that might be a bit more specific when it comes to just wearing people down before it actually raises its head in crisis?
Oh boy, it would be so variable. I think the thing...
I expect it would be.
Yeah. It's hard for me to say it's this. I couldn't say it. I couldn't say it's this. I think it's a combination of just kind of understanding, that you're going to be under a tremendous load, and that making decisions moving forward on how to manage that is not a laid out path. It's going to be full of mistakes. And, the reason you usually understand you've made a mistake is when there's some distress attached to it. Like if you make a mistake in your life and there's no repercussion, there's no emotion, there's no payback, there's no kind of like someone giving you grief, there's no feedback, then you're not going to make any changes. So I think my advice would be watch for change. Watch for those feelings. Understand that when you are a caregiver, if you're just starting to be a caregiver, understand if you watch these podcasts, understand that it's going to be challenging, that it's not going to be easy, and things are going to change. And human beings predominantly don't do well with change. We don't like sudden changes. We love routine, and we build towards that. So change is something that's difficult for people. And when you feel that change and you feel that distress around these change issues, that's when you need the outreach start. You can start support programs quicker. You don't have to wait till you're on the big R with resentment, as we talked about earlier. You could start these things proactively. Like, once you're at the stage where it's like your pain is not manageable acutely, and you've been managing this for like 4 months, 6 months, that is chronic pain. Some people argue it's 3 months. I mean, if your partner is in pain for that long and the interventions might make a little dent, but it doesn't change their life experience, understand where you are. Mm-hmm. That you're in a spot that you're going to need help eventually. So I think you start looking early. That is also, word to the wise. Look early and try to be honest and communicate what you're not good at with people who might be able to help you.
So I'm assuming that we may have some listeners for today who are actually listening as couples, caregivers, and the person they care for who has chronic pain. So. Can you tell me, as a caregiver who knows that they can't fix it, but they believe in the pain experience of the person they love, what does good validation in real words sound like in the ears of someone with chronic pain, hearing those words from their caregiver?
Yeah. I think the most significant change that I've seen in relationships where chronic pain has upended the apple cart, it created all these problems we're talking about. I think it's when I see two patients come in and they're holding a hand and they weren't before. Or when I see two people talking and it's not pressured and it's not venomous. There's like a genuine interest in who they are. I think these scenarios push you away from the people, from the person you love, the person that you gave yourself to. And I said earlier, or, at least I hope I said this earlier, that person's still in there. That person you fell in love with doesn't have to be dead. That person that you appreciate, that, was with you in years of marriage, if that's what your situation is. That person who you had children with, that person who you had your, first kiss with, if that's what the situation is. That person's not dead. And sometimes to look for that person through all these things we've talked about in terms of changing and looking at resentment and the care process and, listening and reflecting, that says that's love. That's love. Respect is love. The opposite of resentment, in my opinion, is respect. Right? Let's go to another R, a good R. And respecting somebody means that you appreciate, in my opinion, what they do. I respect you for your ability to kind of have a smile in a hard day. I respect you for those small things that you did do, and still have in you, but have been buried. And this is why I say often, I talk about people, live your life in spite of chronic pain. Don't live your life under chronic pain. Yes, it's a big road. Yes, it's a big ask. But if you are willing to take a step, if you're willing to not let that love die, if you're willing to kind of be vulnerable and try to find that person again, I think that is the outcome. That's the process. Couples who were in love can always stay in love, but you got to work for it. And that's the difference.
To paraphrase something I read recently, and I can't quote you from where, but it resonated, but the opposite of love isn't resentment. The opposite of love in this context is not hate. The true opposite is indifference.
Bingo. Because all those words you just mentioned, kind of indifference, resentment, it's a cascading, it's a big bingo ball tumbler full of garbage. And, resentment probably is the ball that pops out that day. It's like, this kind of indifference is resentment. It's contempt at its worst. And that's why I say to people, try to find that love. Like, I know it gets buried. I know that it gets lost. It's kind of gets put under. But if I was giving advice to any couple about how to try to be happy in your relationship, it is about finding that love. You just have this blanket of chronic pain and all that crap that it can bring to you to try to navigate. But I think when you start trying to navigate that and you stay open to finding love, you're my love. Start with simple statements. You're my love. I mean, you're still my love. You're my love. And get away from your still to you're my love, right? Those types of statements can also be helpful. You're just doubling down on that feeling.
What I'm hearing here, although we've gravitated a little bit to, spousal, if you will, partnership, caregiving, but I think that some of these important lessons can apply if you're a child looking after a parent in chronic pain or a parent looking after a child in chronic pain. There's a lot of overlap here. So let's not put the blinders on, or as you said, not see the bookcase behind you and just your face. But there's a lot of adaptability here. As a caregiver taking the initiative, we might want to micromanage so many elements with the focus on preservation and positivity, but you could paradoxically make life that much smaller by micromanaging the caregiving environment and everything. Like, where's that sort of fine line, or is there boundaries that we still need to respect in the relationship so that love can actually be nurtured?
Yeah, that's a really good question. I was thinking about something like that earlier. And one of the things that is a killer in, at least in the chronic pain literature, and when we look at relationships, and we look at kind of like caregiving behaviors, like spousal interactions. And we've done a bunch of work with this in, abdominal pain conditions. And one of the things that's come back in our research and other research as well is this idea of solicitous responses, or doing a lot for so much for the other individual that you create a vacuum for greater disability in that person.
Mm-hmm.
So one of the things that I think is really important to understand when I talked about boundaries, right, is like the expectation is that, you're going to do stuff. Like, I think one of the things that hurts caregivers the most is when an individual completely rolls over. Like they give up to that burden feeling they have. They give up to those dark thoughts. They give up to kind of that fatigue on that day, every day. They don't fight for who they are in that day. And I want to make sure that our listeners understand that that is okay if that happens, right? But if it becomes a bit of a pattern, one of the ways that we see helping to prevent that is that the individual in pain has duties. The individual in pain, and a lot of treatment programs, chronic treatment programs, will look for activation in the patients as much as humanly possible. So I'm not saying that if you're out with a chronic low back injury and lifting a 2-pound or 5-pound sack of potatoes is out of the question, that's your job for the day. That doesn't make any sense. But if there's something that you can accomplish in that day, and you have to navigate and negotiate these things, if there's a behavioral task that you can get done that day, like one couple comes to mind. This lady was like, I love doing laundry, but I can't do laundry because I can't get the wet clothes out of a low washing machine and put them in a high dryer. And she was destroyed by this. and depressed, like feeling very upset about herself, the burden. She always, said that, he, the husband at the time in this relationship, doesn't understand how to do laundry. I feel again like another failure. So this was a big point. So what we did was we talked about, well, what can you do? If you can't execute that, are there alternatives? Or occupational therapy comes in. What are things that you can do to manage this because of this back pain? So one of the things that was actually very interesting was that she eventually said or learned to get to a place where she could go down on one knee to relieve some of her back pain, reach into the washing machine with an extender, like a grabber, like one of those, it's like a rod and you pull and little hand grabs things, and pull out laundry and then into a little bucket and then transfer that little bucket onto a little platform and a little platform, a little platform. So it took her a lot longer to do it, but through these adjustments that she would never have contemplated, she was able to get it done. And she felt like, how did she describe it? Success. Now, that took a lot of work. That was for her a done deal. Never able to do it. I'm a failure. I can't even do this. And through those efforts of being aware, facing the emotions, talking about what the task was, looking at, you want to have tasks in your day, make you feel better. Let's get to those tasks. That whole process changed the way she felt on a daily basis because she did little loads of laundry now. So she did laundry every single day, small loads. Everything had to change, but boy, that led to kind of an unburdening of kind of that feeling of loss. So I hope
process.
I hope that's an example of a process.
Yeah. A process that could be applied to so many situations, so many challenges, and the way you break it down and then systematically rebuild it to achieve what relieves that sense, with nothing worse than a sense of failure.
Yeah.
I hear in this case that as a patient with chronic pain, you don't want to fall in the trap of learned helplessness where everything gets made smaller, but at the same time, you don't want to be reductionist as a caregiver and making everything so much smaller for the person you care for so they don't have the opportunity to overcome that challenge that you outlined.
I always say this, let them go.
Mm-hmm.
And what I mean by that, let them have a voice in what they think they can do. What's your ceiling? What can you push into? Like what can you get done? And then, where do you want to go? Do you want to get better at this? And if you hit a ceiling that you can't do something functionally better, then how can you change to get to a different place where you want to be? That's process, that's change. And that change makes huge differences in attitudes. And those attitude changes help with deepening relationships like I talked about. It's so rewarding for a partner to see somebody smile in a task that used to cripple them mentally.
That moment is priceless.
Absolutely. That's love.
So Dean, thanks so much for being here today. One last question. If there's a caregiver listening today who feels totally trapped, what's the first practical thing to implement change that can help them this week?
Oh boy, totally trapped. Get outside. Get outside, breathe, get some fresh air. Try, if you're able, try to just give yourself some space and take some deep breaths and know that even by taking that little piece of time, you could be stepping into a process of thinking about how to move forward. So any small act like that is an act I want you to think is something that's moving you. That is, I'm trying to build hope.
Create space for those moments, eh?
Creates a little bit of space.
Where sky meets tree. Thanks so much for being here.
Thank you.
You've offered us so much practical advice, and I'm sure everyone listening is better off for you having been with us today. Thanks for coming back. No guarantees when you invite someone they'll ever come back, but we're thrilled to have you here. And Thanks for helping us take this places. Folks, that wraps up another episode of the Caregivers Podcast. I'm your host, Dr. Mark. We're so happy you're here. Share your comments, send a review, tell us how we're doing. We're really trying to make this something about you. We'll see you next week. Before we wrap up, I wanted to remind you of something important. The conversations you hear on this podcast are here to inform, to support, to spark reflection. They're not a substitute for professional medical advice, care, therapy, or crisis services. Listening to this podcast does not create a doctor-patient or caregiver-client relationship between us. If you're facing a medical concern, health challenge, a mental health challenge, or a caregiving situation that needs guidance, I encourage you to reach out to a qualified professional who knows your story. If you're ever in crisis, please don't wait. Call your local emergency number or recognize crisis hotline right away. You deserve real-time help and support. The views you hear on this show, whether from me or my guests, are our own. They don't necessarily reflect any organizations we work with, or are part of, or have worked with, or been part of in the past. This podcast is an independent production. It's not tied to any hospital, university, or healthcare system. Thank you for being here, for listening, and most of all, for taking the time to care for yourself while you continue to care for others. I look forward to hearing from you.